Vishad.
Thank you, Vinod sir, for that kind introduction. And let me at the outset thank Dr. Shabir and Balashnan sir and the team Gujarat for giving me this opportunity. I'll start with this case. A 54-year-old lady with a total duration of illness of 2 years presented with deformities involving the distal interphalangeal joints and the proximal interphalangeal joints. Pain predominantly was there on using the hand joints with some force. There was not much significant rest pain. However, she complained of severe pain with minor trauma to fingers. If she accidentally stuck her fingers to an object, then that would be the time she felt the maximum pain. And on examination, the swelling involved the DAP joints and the PAP joints of both hands. And there was bony swelling along with some soft tissue component and deformities were present. This ESR of this patient was 42, CRP was 6, and RFCCP was negative. And this is the X-ray hand, which shows the typical appearance of an osteoarthritis with, as you can see, the joints, the subchondral sclerosis, erosions, and joint space narrowing, especially involving the DAPs and the PAPs. So this is a case of hand joint osteoarthritis, as is very obvious. And as Hunter sir had mentioned in his previous talk, hand joint osteoarthritis is a condition which predominantly involves these joints, that is the DAP joints, PAP joints. Sometimes it can involve the MCP joints, thumb, first CMC joint, and the scaphotrapezial joint. And for some of us who are sticklers to diagnostic criteria or definitions, these are hand osteoarthritis has been defined clinically, radiographically, and symptomatically, and can follow any of these definitions. So as I mentioned, this patient is having a typical hand osteoarthritis, and this patient has got narrowing of the involvement of the DAP and PAP joints. So he has got nodal OA. You can appreciate the node as well as the soft tissue swelling here, the erosions here, as well as the first CMC joint involvement. So this is the scenario. Most hand osteoarthritis can have involvement of all three sets of joints, although one of them would be more predominantly involved, symptomatic. So what would be the natural history of this patient if this patient presents to us in the OPD? So there are many studies which have looked into the natural history of osteoarthritis. So this is a study which was done in Johnston County, and nearly a 10-year follow-up data where they have actually looked into patients who had initial osteoarthritis, and they have looked clinically as well as radiographically after a period of approximately 12 years and seen how many of them have progressed. And what they found was that there was radiological progression with respect to involvement of additional at least more than 2 joints in about 80% of patients over a period of 12 years. And symptomatic hand osteoarthritis, however, was less common but no less significant, because about 1/3 of these patients developed symptomatic hand osteoarthritis in new joints after a period of approximately 12 years. So hand osteoarthritis is by no means a very benign or innocuous condition. It can be troublesome. It can progress radiologically, but thankfully majority of them do not become symptomatic, but ones who become symptomatic are quite significantly affected. So what are the symptoms that we target when we are dealing with osteoarthritis, hand osteoarthritis? So patients can have pain, they can have stiffness, they can have loss of function, and many of these patients actually come to us because they have aesthetic dissatisfaction. They have swelling in the PAPs, especially the younger patients. They are very concerned about the swellings and what would be the outcome of these swellings. And then we can always aim to treat deformities and radiographic progression once we have appropriate drugs for that. So how do we treat hand osteoarthritis? So I would like to briefly highlight these 2 existing criteria. One is the 2019 American ACR criteria for treatment of osteoarthritis of hand, and they have divided into non-pharmacologic therapy and pharmacologic therapy. Of course, the approved non-pharmacologic therapy, as was dealt earlier, includes the CMC joint or orthosis and exercise programs. Then you have the pharmacological therapy, where they have strongly recommended the use of oral NSAIDs, conditionally recommended the use of topical NSAIDs, intraarticular steroids, and chondroitin sulfate. But these have been all that they have recommended with respect to treatment for hand osteoarthritis. What about the EULAR criteria? The 2018 EULAR update recommendation for management of hand osteoarthritis. The only difference, main difference from the ACR criteria is that they have included topical NSAIDs as the first line in the therapy of choice in hand osteoarthritis as against the ACR criteria, where they felt that topical therapies actually is fraught with risk because people can take the drug to the eyes and cause discomfort to the eyes, so they try to avoid that. But apart from that, they have said that you can use chondroitin sulfates, NSAIDs, intraarticular steroids, may be considered in patients with painful interphalangeal joints, and of course should not be treated with conventional or biological disease modifying anti-rheumatic drugs. So how do I manage patients with my patients with hand OA? So first of all, I assess the patients for pain. The pain in patients with hand OA can be acute or chronic. Very often, those patients who come with very severe pain, they have an acute precipitating factor. This could be an excessive repeated strain injury or excessive force that has, trauma that has happened to the hands. And if there is this precipitating factor, then you try to address that. Also, we need to assess for hand disability. What is the occasion that this patient is having? Is she somebody who is a tailor? Then, of course, involvement of the first CMC joint is going to be troublesome. Somebody who loves embroidery, first CMC joint involvement is going to be troublesome. Of course, then look for swelling, because swelling could be an indication that there is possibly an underlying inflammation also in these patients. Aesthetic issues and its impact have to be addressed because these are quite significant, especially as I mentioned in younger patients, and also look for acute phase reactants. So for those patients who present with acute pain, that is, they are often have a precipitating factor like trauma or repeated strain injury. So I advise them to give rest to the joint, give splinting to the appropriate splinting to the joint, give systemic NSAIDs for 1 to 2 weeks, followed by topical NSAIDs. And then most of these patients are called up for reassessment after about 4 weeks. And once the acute pain settles in, these patients are enrolled into individualized hand exercise programs in consultation with the physiotherapist. So what is the role of NSAIDs in management of hand osteoarthritis? There are very good studies which have looked into the role of topical as well as oral NSAIDs, and the efficacy is pretty good, but however, there are potential implications of long-term adverse effects on long-term use. So these may be, the usage may be cut down to the minimum, except maybe topical NSAIDs where you can be more liberal with its usage. So what about those patients who have come with chronic pain, or these patients who had the acute episode subsided but they have gone into a chronic phase? So most important thing is to avoid triggers. So those people who have got CMC joint or hand joint osteoarthritis, avoid squeezing clothes or making duff. Hand exercise is very important. Every hand exercise should be done in identifying the exact positions at which the joints become strained. So it has to be individualized according to the patient. I use topical NSAIDs for SOS for pain and glucosamine 1500 milligram per day. So there are some special situations where some other drugs may have a role. So most common is when there is a calcification along with the presence of hand osteoarthritis. In those patients with calcification, a trial of colchicine may be tried for a period of 4 weeks. Of course, the recent color study has showed no effect in hand osteoarthritis, but they did not particularly look into those patients who had hand calcification. For patients who have soft tissue swelling, erosive OA, and raised acute phase reactions without other causes, I do prescribe a low-dose steroid which is to be tapered over a period of 4 weeks, and then reassess the patient. If the patient is improving, wait and watch. In case of relapse, these patients may be taken for a trial of disease-modifying agents such as methotrexate. For single joint, intraarticular steroids are often beneficial, especially if they are painful, as was mentioned earlier. The only exception is that CMC joint OA, in most CMC joint OA, the injections are not very helpful. I mean, as per personal experience, injections are not very helpful, nor are steroids or methotrexate. So how evidence-based is this practice? So this is the recently published HOPE trial, which looked into the results of 6-week treatment with 10 milligram prednisone patients with hand osteoarthritis. This is a double-blind placebo-controlled trial which used patients with inflammatory osteoarthritis with significant pain. So they had a pain score of at least 30 millimeter, and who had inflammation as demonstrated by soft tissue swelling or edema or by ultrasound. So 10 milligram prednisone was used for a period of 6 weeks, tapered over 2 weeks, and another follow-up period for 6 weeks. And this very impressive result actually they have got that there is a significant reduction in the pain was score after end of 6 weeks, but once the steroid was stopped, tapered and stopped, the pain did come back. And ultrasound synovial swelling also showed significant drop at the end of 6 weeks following treatment with 10 milligram of corticosteroid. And what about the role of methotrexate? This is the recently published method study to treat hand osteoarthritis with synovitis. This is an Australian study. The hand OA was defined by synovitis by MRI. Methotrexate at a dose of 20 milligram was used. Previous studies had used a lower dose at 10 milligram. And these patients were given methotrexate for 6 weeks. And the outcome was improvement in hand pain. And what they found was that was pain at 6 months was better showed a better improvement in the methotrexate group as against the placebo group, and this difference was quite significant. So indeed, systemic corticosteroids and when appropriate, use systemic corticosteroids and methotrexate would have a role in management of hand osteoarthritis. Prescription-based crystalline glucosamine is another agent which has been going on around for quite some time. There are multiple studies. This is one of them in hand osteoarthritis. It's a retrospective study which looked at the usage of prescription-based crystalline glucosamine sulfate at a dose of 1,500 for a period of 6 months. And what they found was that in those patients who took their glucosamine, there was a reduction in pain was as well as function score improved in patients with hand osteoarthritis, indicating that this may be an effective treatment, at least in some of these patients with hand osteoarthritis. So as a practice, intraarticular hyaluron, PRP and biologics are not usually used. So how long to treatment? Usually in hand osteoarthritis, what we find is that there is a phase of inflammation. Inflammation triggers remodeling, and this cycle of inflammation and remodeling finally comes to a equilibrium, and when the joint has sufficiently remodeled, the disease stops progressing. So very often we are able to stop treatment by about 3 to 6 months or so, and some patients do relapse after that, in which case it can be restarted. So what about the future trends in treatment of osteoarthritis? This is one area where drug repurposing has been extensively tried, a very common disease, something where multiple clinical trials with advanced drugs are not possibly feasible, but because there is possibly a metabolic factor involved, it is an exciting area for research. People have tried all sorts of medications for existing medications, even from metformin to GLP agonists to atorvastatin for treatment of hand osteoarthritis. And one of the recent successful trial that has come out is of the denosumab, the rankle blockade for erosive hand osteoarthritis, which was recently published. What this study has showed is that denosumab, as you know, is a rankle inhibitor, inhibits osteoclast activation. This study used gave 60 milligram of denosumab every 3 months to patients with erosive hand osteoarthritis and assessed radiographic progression at the week 24 and 48. And all patients who received denosumab till 48 weeks, denosumab or placebo till 48 weeks, anyone who was willing to continue were given denosumab for the next from 48 to 96 weeks. And what they found was that the primary endpoint was the improvement in radiological score at week 24, and what they found was that there is a significant improvement in the radiological score at week 24 as well as 48. And the number of new erosive joints also showed a statistically significant decrease in patients taking denosumab group as against the placebo, indicating that this could have a role in disease modifying patients with hand osteoarthritis. So this is, as I said, is an exciting area of research, lot of research going on. Mainly four pathways are targeted. There are drugs targeting cartilage breakdown or regeneration, like autologous chondrocytes, FGF18, agglutinases, and MMP inhibitors. Drugs targeting subchondral bond formation are being tried, like cathepsin inhibitors and bisphosphonates. Drugs targeting inflammation, like disease-modifying agents and biologics. And drugs targeting pain pathways are also coming up, like NEGF and TRVV1. So to sum up, hand joint OA can be a cause of significant morbidity. It can cause pain, loss of function, and stiffness. It not always requires aggressive treatment, but in certain patients it requires active intervention. Short-term pain relief with rest and NSAIDs should always be given. Long-term disease modifying, the role is debatable, but if we probably choose the patients properly, we may have a good result. And it is important that no two OAs are similar. Patients may have hand OA, but no two hand OAs are similar. It is important to individualize management, at least with whatever knowledge that we have till now. Thank you.